Hi class, my name is Anna Mulak and I'll be doing my oral presentation on a Psych SOAP note. So I was at a primary care office, Primary Care Physicians of Hampton Roads in Virginia Beach. TT, date of birth 1/1/97, age 27, white male, presented to the clinic alone. He appeared to be a reliable historian, and his chief complaint was that he stated, "I've been having a hard time since I left the military." Patient recently transitioned out of active duty service 2 months ago. Patient reported feelings of irritability, difficulty concentration, no motivation, episodes of sadness, difficulty sleeping, using nicotine and alcohol to numb the feelings. So this case was significant to me because my husband's active duty, and that's why we moved to Virginia Beach. So we see plenty of active duty and veterans at this clinic. And this also points out a larger issue that the military community faces in and transitioning out of service. It's also interesting because this patient had multiple active problems going on that you have to focus on: social aspects, community, physical, everything. So to further dive into the case, like I said, TT, 27-year-old white male, presented to the clinic alone, reliable historian. Their complaint was that they have been having a difficult time since leaving the military 2 months ago. Reports of irritability, difficulty concentration, no motivation. Patient states mood swings, episodes of sadness, difficulty sleeping. They sleep on average 4 hours a night total, and they have difficulty staying asleep, but denies nightmares. Patient states that they drink alcohol to help numb the feelings, but then afterwards it makes the feelings worse. State they drink about 3 days a week and on average 7 drinks per episode. They deny any suicidal ideation. Past medical history list is only positive for eczema, no past mental health diagnoses. Surgery-wise, have wisdom teeth removal and LASIK. Allergies, no allergies to medications, foods, allergic to dust and cats, and medications, a Dermasmooth just for the eczema, and social history. So, current use of Zyn, the nicotine, 1 can a day. Like I said, binge drinks multiple days a week, average 7 drinks per binge times 3 episodes per week. Denies any drug use. Recently moved to Virginia Beach and has no support network or family here. Calls their mother every day. They are single, unemployed, seeking work, Catholic. They exercise only once a week and fast food almost every day. Family history. Mother is positive for anxiety. Father has hypertension, hyperlipidemia, and alcoholism. Sister, no medical history. Maternal grandma, hypertension, osteoarthritis. Maternal grandfather, alcoholism, and no known on the paternal grandparent side. Review of systems. Patient had denied fever and unintentional weight gain, weight loss, fatigue. Fatigue, yes, because of the no sleep. Patient stated no feelings of skipped beats or fluttering, no chest pain. Patient denied any difficulty breathing, cough, shortness of breath. Neuro-wise, denied any dizziness, blurred vision, numbness, tingling, any seizures. Psych-wise, though, the patient complains of insomnia, sadness, irritability, anxiousness, difficulty concentrating, low motivation, denies nightmares, flashbacks, suicidal thoughts, or thoughts of hurting others. Endocrine, patient denied cold or heat intolerance, polydipsia, or polyphagia. Vital signs, all normal, none out of the ordinary. Diagnostic screenings, PHQ-9 was done, score of 4. Cage questionnaire, score of 3. Upon physical exam, general, cardio, respiratory, neuro, endocrine, all unremarkable. Psych physical exam, mood was flat. Rumination was seen about past military events. Judgment was intact. No delusions or hallucinations, and no suicidal thoughts. So, upon my assessment, a couple differentials were brought up. So my first differential is adjustment disorder with mixed anxiety and depressed mood. So this is shown, it's a maladaptive approach emotionally and behaviorally to a stressor, such as moving out of the military, moving to a new place, loss of a loved one, but it is an overreaction to that stressful event. And this meets the DSM-5 criteria, all of their factors, and this is most in line with what's going on with that recent, within 2 months, moving out of the military and not having other supports. They're also showing signs of anxiety and depression, and that's all in one diagnosis. Differential also would be post-traumatic stress disorder. So the DSM-5 states that the patient had to experience a traumatic event and have distressing memories, such as bad dreams, flashbacks, and this patient is denying recurrent nightmares or flashbacks and no acute traumatic episode. And then major depressive disorder is also a possible differential. It's characterized by a chronic depressed mood, loss of interest, poor appetite, sleep disturbances. This patient had a PHQ-9 score of 4, so we're on that cusp, but it's not necessarily a primary diagnosis at this stage in time. So resources that I use to come up with all these differentials. DSM-5 is huge anytime it comes to any psych, and then I also use the World Psychology Journal. And we decided with critical thinking to come up with the adjustment disorder with mixed anxiety and depressed mood as the primary, because this fits the most criteria for what this patient is going through. It's been under 6 months since the stressor. The only other thing that we wanted to address is a secondary diagnosis of possible alcohol use disorder due to the amount per week in the positive CAGE questionnaire. This is a condition that we'll need to continue to assess and watch for until the drinking causes significant impairment or distress to officially diagnose that as alcohol use disorder. So, our plan, I do want to run some diagnostics to make sure that we're ruling out any other causes of the insomnia, fatigue, anxiousness. So, ordering CMP, TSH, CBC, vitamin D. And for treatment, we're going to refer to cognitive behavioral therapy and a substance use counselor or a support group. Education is going to be huge. We want to educate the patient on the risks of binge drinking, nicotine, and the effects on sleep hygiene in general. So we want for sleep to be a consistent schedule, limit screens before bed, exercise regularly, and limit caffeine and alcohol. And then we also provided information on a local veterans center that offers transition assistance, including employment and mental health services, and we provided a local AA program. We will follow up in 2 weeks to assess the response to initial treatment. We want to monitor the alcohol nicotine use, and we want to review those labs. Patients should go to the ER or call a helpline if they're having suicidal thoughts, chest pain, or shortness of breath. So we chose this therapy and referral because CBT has shown through research, including randomized controlled trials, to be the most effective treatment for adjustment disorder. And the support for our education with alcohol and nicotine with sleep and how sleep affects mental health is shown through many studies that we've referenced below. And then we did consider some alternatives. So studies show that medication and CBT can be used, but we want to start with the CBT and see how he does with that. This patient didn't necessarily want to start on any medication, so we took that into consideration. Other alternatives that were addressed were if we wanted to do family therapy. At this point in time, it didn't make sense, but we can look at that on later. So we collaborated with a couple different things here. So we are collaborating with that CBT therapist. We're collaborating with that Veterans Health Center and collaborating with an AA program. We could collaborate more with the family or a family member and a religious group for support. And then I used some of Gene Watson's caring processes in this process. We developed a sustaining, loving, and trusting caring relationship, nurturing that bond with the patients so that they feel trusting and cared for. We held space for them as well. We allowed for expression of positive and negative feelings without judgment. We listened to their entire story. And this was representative of a holistic approach because we did mind, body, soul, checking diagnostic labs to see if there's any other physical processes going on here causing this. And then the referral to CBT for that mental health. And we also considered their social support systems, their religion, their family, and what else we can do to support them in their employment. So the whole holistic approach was done here. So thank you so much for listening. Let me know if you have any questions, concerns.